Good evening, everyone that's joined so far. Got a few people joining online. We'll wait to start in about 2 minutes. I'm Rebecca Mitchell. I'm an O&G consultant based in Melbourne, and I'll be facilitating tonight's webinar for PSRH. We'll just wait a few minutes for people to join on, and then we'll start.
Rebecca, do you want to bring up your first slide?
Not a problem.
Names on? I wonder what the weather's like in the Pacific, isn't it? It must be nice and warm.
Sure, much nicer than Melbourne.
It'd be much warmer than Melbourne, I think.
I'm sure.
Right. Well, it's 5:01, so we might make a start. Welcome to tonight's COVID-19 vaccine rollout in the Pacific webinar that's facilitated by the Pacific Society of Reproductive Health. I'm Rebecca Mitchell. I'm an O&G consultant based in Melbourne, cold Melbourne, and I'll be facilitating tonight. By the way of background, I'm on the RANZ Cold Global Health Committee, and I myself have worked in both Papua New Guinea and the Solomon Islands, and might know many of you. Tonight we have Professor Michael Toole and Lisa Davidson from Burnett, who will be talking to us about the vaccine science, as well as overcoming vaccine hesitancy in PNG. Hopefully Sister Jennifer will also join us online and talk to us about the PNG frontline and vaccine rollout. Thank you very much to our panel tonight. Without further ado, Cara will kindly commence the night with an opening prayer. Thanks, Cara.
Okay, let's just open with a prayer. Hamatulu matuna ha ha he langi. Pakaue atu matulu kia koe ke mga honi. Lang matai whakalahi mai koe hamatulu ke mga honi ke hamatulu te whakakoanga ke lang matai ke matulu te watu motu Pasifika. Koe hawa I ngō kua hole atu matulu kia koe. Mo whakaue atu matulu kia koe. Amen.
Thanks, Cara. So I will now hand over to Professor Mike Toole, who was from the Burnett Institute. Thank you very much for joining us tonight. And will talk to us about vaccines, the science, and give us some global data. Feel free to ask questions as we go in the chat or in the Q&A pane, and we can ask them as we go along.
Good evening, everybody. So I was going to give an overview of the rollout of vaccination in the Pacific, and then look at the different vaccines that are currently available in the world. And currently there are 8 or 9 that have been approved in at least one country. First of all, I should remind us of the global situation. So you can see that we, the world, are in, I guess, a 3rd or 4th surge in cases. And you can see by the yellow part of those bars that it's being dominated by Asia, which wasn't the case before. It was more like the Americas and Europe. So this time it's an epidemic or a wave driven or fueled by Asia. As you probably all know, India is reporting 300,000 to 400,000 cases a day. But as of today, I can only see 2 countries in Asia that are not currently experiencing a surge, and they are China and Brunei. Every other country is in the midst of a 2nd, 3rd, or 4th wave. So COVID in the Pacific region, what's called Oceania, has the lowest rate per population of any region in the world. French Polynesia has reported the highest number of cases, and its cumulative incidence rate per population is one of the highest in the world. It's then followed by Papua New Guinea and Guam. And then you go down to triple digits for all the other countries. And of course, there is Fiji, has now reported 178 cases, of which almost 2/3 have been reported since the middle of April. It's only reporting 4 to 5 to 6 cases a day, but it is of concern that they are often unlinked cases. So it is in the community. And there's a number of countries: Cook Islands, Kiribati, Tuvalu, Nauru, Niue, FSM, and Tonga have reported no cases. But new cases continue to surge in Papua New Guinea and Timor-Leste. Now, 2 weeks ago, I showed this graph to our staff meeting at Burnett in Melbourne, and it seemed to show a steady decline in the 7-day rolling average of daily cases in Papua New Guinea. However, we were receiving via our staff reports of underreporting. And there was an item in the media that, that showed that in Western Highlands province, of the cases that were recorded by the provincial health authority, less than a half were actually being reflected in the national figures. And that also applied to deaths. Now, as of today, it's a very different picture. So there were obviously a backlog of positive cases that have only this week reached the National Department of Health. And so you can see that we don't even know if this is true, but because Papua New Guinea has such a low testing rate, but at least the official figures are back where they were 2 weeks ago. So that country is not out of the woods yet. So how about the global vaccination rollout? Oops. Now, this is a map from the New York Times. It's a good one to check every now and then. So globally, 1.5 billion doses of vaccine have been administered, which is about 19% of the world's population. But those doses are very much concentrated in the rich countries of the Northern Hemisphere, Europe and North America, as well as China and India with their very large populations. Now, the darker the green is, the higher the number of doses administered per 100 people. And you can see to the left, very high in the US and Canada, also the UK, and a number of European countries. In the Asian region, Mongolia and tiny Bhutan have the highest vaccination rates. Otherwise, and also Singapore. Otherwise, Asian countries have quite low rates of vaccination. So this data, this is of this morning, and there's a combination of sources: the New York Times, the Our World in Data project at Oxford University, and also some media releases, because Nauru and Palau are not included in those databases that I mentioned. But it looks like Nauru has actually vaccinated more than 100% of its population, because it also vaccinated foreigners. Palau is the same. Guam is very high, and of course it's one of the territories that is supported by the US vaccination program. Likewise, the Marshall Islands and the FSM, Federated States of Micronesia. Then we go down to New Caledonia, which is supported by the French program. Then if we look at independent countries, Tonga is the highest that I could find, 21% vaccinated with at least one dose, and just over 1% fully vaccinated. Australia, we don't publish our fully vaccinated figures. I don't know why, but we have given at least one dose to 13% of the population, followed by Fiji and Samoa at 10, and New Zealand just under 10, and the Solomon Islands at 2. Now, the Solomon Islands is the only country that in the small Pacific Island countries that is using 2 vaccines, and that's AstraZeneca and Sinopharm, which is produced in China. And PNG, you can see, is very, very low. In fact, it's the lowest country in the New York Times database, at fewer than 0.1%. Now, these are the currently approved vaccines. I'll take my time to go through these. There are a couple of other vaccines that are approved in, say, one country, like this, a third vaccine in China that's been approved. And there's a second vaccine in Russia that's been approved. But here are the 8 that are basically available to the world. So Pfizer and Moderna are both mRNA vaccines. And what they've done is they've taken the part of the RNA from the virus and introduced it in as a vaccine. And that induces the body to make these spike proteins that resemble the real virus. And that induces an immune response. So when the person who's vaccinated meets a real coronavirus, they mount a very effective immune response, both in terms of neutralizing antibodies and the CD4 and CD8 T cells that may actually be key in inducing long-term immunity. We don't know yet, because the country that's been vaccinating the longest in the world has only been vaccinating for 6 months, since December. So we know that these vaccines, Pfizer and Moderna, do induce immunity that lasts 6 months. But we know from the flu vaccines, they induce immunity for between 6 and 9 months. That's why we need a new one every year. So we're waiting to see, in 6 months' time, will these vaccines still be just as protective? AstraZeneca, developed by Oxford, is a vaccine that uses a chimpanzee adenovirus to kind of piggyback viral components into the body. You'll see it is approved by more countries, more than 100, than any other vaccine currently available. It's also, you'll see, much cheaper than the 2 mRNA vaccines. And I should go back to the storage requirements of Pfizer. Originally, it had to be kept at -70 Celsius, which is much colder than a normal freezer. So you had to get these very low temperature freezers that are quite expensive. But most recently, the FDA and other bodies have approved keeping Pfizer vaccine between 2 and 8 Celsius, so in a refrigerator, up to 1 month. Back to AstraZeneca, very confusing figures on efficacy. The company's not been very good at communications. The original trial, which is very flawed, by the way, because they gave half doses to some people and full doses to others by mistake. That trial showed 62% efficacy, but recent data, for example, from the US trial, and real world data show that it can be up to 80% effective. It can be kept in the fridge at 2 to 8 degrees. Now, Covishield is the exact same vaccine, but it is produced by the Serum Institute of India, the world's largest vaccine manufacturer. It's the same kind of virus. It has, in only one published study, a 75% efficacy. It's approved by 40 countries. It also can be kept in the fridge, and they have just, I'm trying to move our pictures away to look at the price. It is just a little bit more expensive than the AstraZeneca. So it's 600 rupees in India. Johnson & Johnson is the only vaccine that you require only 1 dose. It is also an adenovirus vaccine. it uses adenovirus 26 as the vector for the vaccine. It has an efficacy of 72%. They have continued their trial to see if 2 doses gives a significantly higher efficacy. And if that's the case, then some countries may choose to give 2 doses. It's approved in 41 countries. Though I see Denmark today decided not to use it, so I guess it's gone down to 40. And it's $10 a dose, so it's in the mid-range. Gamaleya, known popularly, at least by Vladimir Putin, as the Sputnik 5 vaccine, it is quite creative in that it uses a different adenovirus for each dose. So it uses adenovirus 26 for the first dose and adenovirus 5 for the second dose. And the reason the Gamaleya scientists did that was they wanted to avoid interference by people mounting immunity to the adenovirus rather than the coronavirus. And they've ended up with a very good efficacy of 91%. It's approved in a lot of countries. It has to be kept at -18 Celsius. But the most recent advice from the company is that it can be kept in the fridge for up to 2 months, so longer than the Pfizer. It's about the same price as the Johnson & Johnson. Now, the Sinopharm vaccine, I think so far from what we know, is probably the best vaccine coming out of China. It's an inactivated vaccine. So that's a kind of traditional vaccine, like flu, polio, whooping cough. So it uses a killed version of the actual virus. Now, the official efficacy from the company is 79%, but the United Arab Emirates and Bahrain did independent trials. The one in UAE was quite big, and they both found 86% efficacy. So both those countries are using Sinopharm. As you know, they're both very rich countries, so they can afford any vaccine they want. But they are convinced that Sinopharm is good. The UAE and Bahrain are also using other vaccines. Approved in 42 countries, can be kept in the fridge. It's not a cheap vaccine, $30 a dose, so it's up there with Moderna. But as you probably know, the Chinese government has purchased a lot of Sinopharm and are giving it to a lot of low-income countries at reduced prices or else free. Egypt is getting a lot of free Sinopharm. So there's another Chinese vaccine called CoronaVac, or it used to be called Sinovac. It's also an inactivated virus, but the data coming out of China it hasn't been published. And the only data I'm aware of is from the Brazilian trial, where it was just 50% effective. And that's the threshold that WHO has set for defining an effective vaccine. Only approved in 10 countries, can be kept in the fridge, and it's $14. The last one is Covaxin. That was developed in India, not by the Serum Institute of India, but by another company called Bharat Biotech. But the Serum Institute of India is producing it under license. So it's an inactivated vaccine, has an 81% efficacy. So far only approved in 9 countries, to be kept in the fridge, and currently in India it's $3. I don't know what they're selling it on the international market. So if you have any questions about those vaccines, I should just add one more, or actually 2 more. Novavax is a vaccine that many people in the world are waiting for, because the preliminary data out of the UK were very, very promising. close to 90% effectiveness, even against the British B117 variant. Now, sadly, last week, the company announced that they would not be seeking authorization in the US until the third quarter, and that they have manufacturing difficulties, mainly related to raw materials that are in scarce supply all over the world, particularly these big 2,000-litre plastic bags, which, as far as I know, only one company, Fuji, manufactures. And so a lot of investment's gone into that company to double, triple, quadruple their output. So in Australia, we have ordered 51 million doses of Novavax. So that's the biggest number of any vaccine that we've ordered. But we probably won't be getting it until, I would guess, early next year. But it will be a very useful addition to the vaccines that are available through COVAX. So COVAX is the main source of vaccines in the Pacific, other than some donations by Australia and New Zealand. New Zealand's mainly covering Cook Islands, Niue and Tokelau. Now, Novavax has already pledged 1 billion doses to COVAX, including 390 million doses this year. So if they can get manufacturing going by the fourth quarter, that will be a boost in the arm to COVAX and therefore the Pacific. Because as you know, the Serum Institute of India, which was going to be the main supplier of vaccines to COVAX, is no longer exporting any vaccine. It all goes to India. And that's a huge blow to COVAX. Just one last message about small island countries that are dependent on tourism for a high proportion of their national income, such as Fiji. I think it's up around 40%. These are two cautionary tales. I'll just shift those photos. So Seychelles. Seychelles has the highest vaccination rate in the world. So 72% of people have received the first dose and 63% are fully vaccinated. And yet look at that spike. Seychelles has never recorded so many cases. You can see for the whole of 2020, they barely recorded a single case. But what the Seychelles did, and what Fiji and others must not do, is they opened their border to tourists during the northern summer, mainly from Russia and South Africa. And so some people, they had to get tested, and they had to test negative before they arrived. But as we well know, people can test negative when they arrive in a country and 2 or 3 days later test positive. And that spread. And it spread in both the vaccinated and the unvaccinated population in the Seychelles. The other comparable country is the Maldives in the Indian Ocean. They have fully vaccinated 28% of their population. They've vaccinated 95% of all hotel and other tourist workers, and yet you can see another spike. And the main reason for that was that they opened their borders to tourists from India. And as you may have heard, some Australian cricketers went back to Australia via the Maldives. And you can see that it has spread so rapidly. So that would be my last advice to Pacific countries. Do not rush into opening your borders until you're highly vaccinated and you have a system to make sure no one is bringing the virus into your country. So thank you.
Fantastic. Thank you so much for that, Professor Mike Toole. That was great. It's great to hear about the different vaccines, the different efficacies, the cost, and the storage as well. It's really interesting. You mentioned essentially nine different vaccines, and I was just curious. You mentioned about the WHO having they suggested an efficacy of 50%. Who who sort of worldwide has an overview of the vaccines available and ensures that they're safe and effective, or is it up to the individual countries themselves that authorise the use of the vaccine?
Yeah, well, WHO has their own system of emergency use authorization, and they have authorized Pfizer, Moderna, AstraZeneca, Johnson & Johnson, and Sinopharm.
Okay.
Not yet authorized Gamaleya or Covaxin, but I don't think those companies have applied for it yet. But if you just want information on vaccines, I always go to the New York Times vaccine tracker. They will give you all the details of the vaccines, not just the ones that are approved, but the 80 or so that are in phase 1, phase 2, and phase 3 trial. They get their data from the University of Oxford.
Yep, fantastic. And I was also curious, you mentioned that PNG has one of the lowest rates of vaccination in the world. Do you think that's due to a lack of data and paucity of data, as well as inaccurate data? Or do you think it's actually due to vaccine uptake?
They know how many vaccines they receive. They know how many they administer. They've received, I think it's about 100, more than 100,000 now. It's just problems with distribution and administration in a weak health system. No, the data that I don't trust is the data on cases, because there are big delays. There's under-testing, there's big delays in communicating the results to the national level. But I think on vaccines, it's pretty accurate data.
All right, fantastic. Thanks so much. We'll hear from Lisa now, who will talk more about vaccines, the potential hesitancy. And if anyone has any questions online, please feel free to put them in the Q&A pane, or also put them in the chat. Thanks.
Sorry, I'll just share my screen. Okay. Can everyone see that?
Yes, we can. We can also see that it's on presenter view. So you can either have it on presenter view, or you could just do it with the full screen.
Sorry, yeah, I'll change. Sorry. Sorry, I'll do it again.
No worries. It is frustrating that you can't do presenter view on Zoom, and
Okay. Actually, I can't get it off now.
yeah, if you could just exit the show and then show it on full screen. Yeah, that's right.
Okay, sorry. Okay.
Yep,
yeah.
Beautiful.
All right.
Lovely.
Yep.
Thanks.
So thank you. I'd like to begin by just acknowledging the Dja Dja Wurrung people, who are the traditional owners of the land from where I'm presenting tonight, and pay my respects to elders past and present. I'd also like to thank Mike for his overview. I have the privilege of hearing Mike's overviews each week at Burnett, and they're always so insightful and so interesting. To begin, I'll just let you know that my presentation is going to be focusing on PNG, but I'm hoping that it will have relevance to other areas in the Pacific. So I'm going to begin by just defining what vaccine hesitancy is. So it is the delay in the acceptance or the refusal of vaccination despite availability and of the vaccine and vaccine services. It's complex, it's context specific, and it varies from time, place, and vaccine. It's also influenced by factors such as complacency, convenience, and confidence. So we'll just look at those three a little bit more. So complacency is if the perceived risk of the vaccine preventable disease is low, then the vaccination is not deemed a necessary action. In the case of COVID-19, vaccine complacency also relates to the perceived risk of adverse reactions or side effects associated with the vaccine, weighed against the perceived risk associated with the COVID-19 infection. Convenience refers to physical availability, affordability, willingness to pay for, geographical accessibility, ability to understand, including both language and health literacy, and finally, the appeal of the immunisation services to the extent to which this may affect vaccine uptake. And lastly, confidence. Confidence and trust in the vaccine, confidence and trust in the delivery system for the vaccine, and confidence and trust in the policymakers who decide which vaccines are needed, when and where. So in March 2020, the Burnet Institute began working with local partners, the National Department of Health and the provincial health authorities in PNG to prepare and respond to the COVID-19 pandemic. Fortunately, throughout most of 2020, PNG experienced isolated COVID-19 cases, mainly confined to fly-in, fly-out workers. However, throughout the year, there was very little community testing, so it was really unclear whether there was undetected community transmission. In the beginning of 2021, there were a number of large community events that encouraged gatherings of people and the mass movement of people from the villages in the provinces to the capital, Port Moresby, and then back home again. Unfortunately, during these social gatherings, neither social distancing or the wearing of masks was mandated by the government. Following this, there was an escalation in the number of COVID cases and deaths, initially in Port Moresby, but soon after, cases were being detected and reported through all 22 provinces of PNG. In February this year, our local team in East New Britain, which is an island to the north of mainland PNG, began collecting data on the COVID-19 vaccine hesitancy. To minimise the risk of transmission for both our staff and the participants, we kept the design of the research really simple. 50 random people in East New Britain would be contacted each month by phone. They would be asked a couple of simple questions. Their details would be anonymous, but they would be asked to provide the sex they identified as, their age, and their employment status. And then there were just 2 questions. When the COVID vaccine becomes available in East New Britain, will you have it? And the second question, why? This survey was conducted monthly for the past 4 months, and I'm now going to share some of the results. So the survey was first conducted in February, and you can see on the left-hand side of the slide a breakdown of sex, age, and occupation. Of the 50 people that were surveyed in February, surprising to our local staff, 47 responded that they would not get vaccinated when the vaccine becomes available. Only 1 person said yes, and 2 were undecided. This result was quite shocking for the local team and became a catalyst to doing more work. In the same week that this survey was conducted, there were 3 confirmed cases of COVID-19 in East New Britain and 38 cumulative cases. However, testing was still only being provided to people who presented with symptoms, and the testing rates were extremely low. There was a general belief in PNG that people were not affected by the virus because they had a stronger immune system. Overwhelmingly, the main reason for vaccine hesitancy was the belief that COVID-19 was not a health issue in PNG like it was elsewhere in the world. Here are just a couple of the responses from that survey in February. A male 38 said people in PNG do not get COVID. A male 42 said we have a stronger immune system, so we won't get sick from COVID like people elsewhere. A female 22 said in PNG, COVID is just like the flu. It does not make us sick. And a healthcare worker said, COVID is just like the flu. It takes longer to develop a vaccine. Why so sudden? I don't trust it. In March, we repeated the survey. And in the week of March the 21st, when the survey was conducted, there were 51 new cases confirmed of COVID in East New Britain, and the cumulative number had gone up just over 100. It was the 7th consecutive week of increasing cases in PNG, with over 100 confirmed cases and 15 deaths nationally. Despite this, the level of vaccine hesitancy remains surprisingly high, with 49 out of 50 respondents saying they would refuse the vaccine. The main reason for refusal had changed from one of denial about COVID-19 to being concerned about the safety of the vaccine. Some of the responses included male 28, no, if I have the vaccine, I'm afraid it might have some other effect on me and cause me some harm. I'd rather wait and see. A male 37, no, I don't want to be affected by the vaccine. It would not be good. They need to trial it first with others. I do not want to be the first. A female 49, no, I wouldn't know if the vaccine was good and I wouldn't know if it worked. Vaccine development takes forever. And for this sudden turnaround time, it is not satisfying me as an ex-healthcare worker. It was just last year and now a vaccine. A female 26 said, no, I've seen many side effects from the vaccine on Facebook. It is not for me. And a male 61 said, I don't believe in vaccines for adults. Vaccines are only for babies. By the end of April, East New Britain had experienced closure of its two busiest hospitals, St Mary's and Nonga, because so many healthcare workers had been infected or were afraid of being infected. In the week the survey was completed, there were 54 new cases and the cumulative number had risen to 371, many of whom were healthcare workers. Despite this, vaccine hesitancy remained high. Many people expressed concerns about the safety of the vaccine. This corresponded with media reports of blood clotting associated with AstraZeneca and the Australian government's announcement to donate AstraZeneca vaccine to PNG. Some of the responses in April were 34-year-old female, I will not get the vaccine because I do not know what type I would be given. Male 34, no, because there has been no vaccine trial in PNG. I am not getting something injected into my body which has just been developed overnight, and I am just being told it is good. Female 36 said yes, because she felt that it would protect her as a frontline worker. 35-year-old female, no, I am scared it might trigger other conditions and complications in my body. Not all people are the same. And then a male 30 said no, because when I look at other diseases like HIV, MDR-TB, which is also an issue in PNG, scientists haven't done anything yet. And with COVID, they took a short time to develop the vaccine. They haven't trialed it and they are just rolling it out. And these are the results from this week. The national rollout of the vaccine of AstraZeneca was launched on the 4th of May, and to date there are only 7,000 vaccines have been administered nationally. During the week ending the 8th of May, there were 76 newly diagnosed cases of COVID in East New Britain. The vaccine hesitancy remains high. However, the number of people saying yes and who are undecided has increased. 32 people said no to being vaccinated, 11 said yes, and 7 were undecided. The reasons given for this have also changed. A 34-year-old female, after all the vaccine talks, I'm still not buying it. I'm still confused because of the first messages I came across on social media. I have decided to wait and see. A male 22, I don't know. I'd like to protect myself and my family, but I'm scared of the reactions. A male 20, I don't know. I'm not sure of the virus and the vaccine. I've heard a lot of stories and I've decided that they are too scary and I do not want to hear any more. However, there have been some encouraging comments as well. Female healthcare worker, I will get vaccinated to protect my family and my community. So what does this tell us? Although PNG is a very fragmented society with over 400 languages and hundreds of wontoks and varying cultural and health belief systems, core to them all is storytelling. Stories are used to explain the unexplained. Stories are used to make sense and fill in the gaps. And stories become myths, and soon they are believed as facts. The COVID-19 story is complex, confusing, and constantly changing as we learn more. For communities in PNG, it has added complexity. These communities have lived with the effects of malaria, TB, and more recently, HIV. They have been constantly told there is no vaccine. Vaccines take a long time to develop. Vaccines cost a lot of money. Vaccines are often developed and then fail, and we have to start over again. Suddenly for these people, there's a new disease, COVID-19, and with 12 months, not one, but many vaccines. They find it hard to believe if this story is true. At the same time, social media has exploded in PNG, and even the most remote communities, they have access to it. Information and misinformation about COVID-19 have been rampant, and social media has played a central role in its dissemination. But how do people learn to tell the difference between the real and the fake news? And to complicate things even more, the real news has conflicting messaging and rapidly changing information. Is it any wonder then that the people in PNG are confused? So why are myths and stories so effective? When we look back over the reported reasons for the vaccine hesitancy, we can clearly see how myths and stories quickly evolve into truths as they are told and retold and shared. This is particularly true when they are also shared and supported by and through multiple sources, including social and mass media. It becomes increasingly difficult to sort fact from fiction. The myths and stories also tend to have an easy narrative to understand and to tell and retell, particularly when they are shared in communities where there are generally low levels of health literacy. Importantly, myths and stories are often told in local languages. This makes them easier to believe, easier to share, and easier to retell. Finally, the myths and stories are more likely to be believed and shared when there are underlying levels of mistrust and fear in the science, in the governance, and in the outside world. This has all supported high levels of COVID-19 vaccine hesitancy in PNG. So how do we mitigate this vaccine hesitancy? Firstly, we need to have a better story. The story needs to be clear, consistent, concise, and easy to understand, easy to repeat, and easy to believe. The story needs to be told and shared in local languages. This helps improve comprehension and makes it much more trustworthy. It needs to be told and shared by trusted sources within the community through local community leaders, church leaders, and healthcare workers. And finally, it needs to be seen, heard, and repeated in and on multiple platforms, including schools, workplaces, churches, marketplaces, social media, radio, TV, and print media. So to address vaccine hesitancy, we need to keep the narrative simple. We need to keep the messages attractive. We need to ensure that our story is relevant. And finally, we need to make sure that the story is consistent. I'd like to thank our local team in East New Britain, so Pele, Duk, Kerry-Ann, Hadley and Pyakalyia, and everyone who participated in the story, and a special thanks to those that shared their thoughts and concerns for the surveys. Thank you.
Thanks so much, Lisa. That's fantastic to hear. Yeah, as Michael Toole's clapping, I'll clap too. That's fantastic. It was great to see that the surveys done of the 50 participants over the months, and to see how the vaccine hesitancy did change, but still stayed significantly high, given the rates of COVID in Papua New Guinea and the rates of concern amongst healthcare workers, and as you said, both hospitals closed in East New Britain. So it was fascinating to hear, and also hear the concerns about the quick development and as you mentioned, Lisa, the underlying reason behind that is probably due to the history of other infectious diseases not having vaccines, and then why have we suddenly got a COVID vaccine, which is fascinating to hear.
That was a concern in a lot of surveys in high-income countries as well. So the early surveys in Australia found that a lot of the people were concerned that it had been developed too fast. That's changed in recent surveys. Now people are more worried about side effects.
Well, that's what I was going to ask, Lisa, in terms of vaccine hesitancy because of side effects. I wonder if you found a significant increase in those concerns and what we're seeing coming out of the likes of Australia, and as we know, they've changed our vaccine policy from AstraZeneca to Pfizer for the younger age group and the risk of blood clots and all of those concerns. How can we manage that and mitigate those concerns?
Yeah, so in PNG, similar to in Australia, concerns about side effects have been enormous. And those side effects have ranged from everything from the vaccine causing infertility to the vaccine being a way that you can be monitored through Bluetooth because you're going to be injected with some type of electronic coding mechanism. It was just
designed by Bill Gates.
Yeah, yes, exactly. So yeah,
I've seen that one on Facebook. Yep.
Yeah, and yeah, I guess because PNG has joined the rest of the world through Facebook and YouTube, it's the same type of rumours and myths that are going around about possible side effects. What we've learnt through other work is it's important that you don't fixate on going into the details of each of these concerns, because the takeaway message often remains with the concern. So it's better to provide people with information that is true, correct, and factual. So when these concerns come up, they can then look at them rationally with some health literacy and decide which makes sense and which don't.
Yeah, because as we've seen with AstraZeneca vaccine in Australia, the risk of blood clots and people's concerns there, and Mike Toole might know, but in PNG they're using AstraZeneca. Is that correct?
Yeah, they're only using AstraZeneca.
Yeah.
Solomons is the only country in the Pacific that is using a second vaccine, which is Sinopharm.
Okay. Yeah.
Everyone else is using AstraZeneca.
All right. Yeah.
I get one of the interesting points that came up, I didn't read it out in the comments, was there are quite a few people that were concerned that Australia was giving the AstraZeneca vaccine to PNG because it wasn't good enough for Australia, but it was going to be good enough for them. So we were kind of trialing it on them to see if it was okay. And that came up quite a lot, particularly in the March and beginning of April surveys.
Yeah, I thought that would happen.
And that's a huge issue to tackle. I mean, as you said, you're trying to keep the message simple and concise, but how do you tackle that? That's got all sorts of difficult political ties and
and lots of
historical ties.
Yeah, lots of baggage and history that is underlying and supports that.
Yeah. So then, do you, in terms of education, do you just continue to educate that the risk versus a benefit of the COVID vaccine?
Exactly. Which, I mean, but you can see the challenges here in Australia where we have higher levels of health literacy, but trying to explain the risks against the benefits is really, really complex. You try and do that in an environment where health literacy is fairly low. Vaccine hesitancy in general was low even beforehand. There was this general belief, why would you give someone an injection if they're not sick? Injections are for when you're sick. So why would you inject someone who's not sick? So you have to overcome that belief, as well as all of the other, stories and myths that are going with the COVID vaccine. Yeah.
I've just noticed a comment in the chat, and feel free for anyone that's online to post a comment in the chat box or ask a question in the Q&A pane. But essentially, it's just about how concerning it is that healthcare workers are not confident in vaccines, and then themselves hesitant to have a vaccine. And again, it is role modeling within the community. So how
that's been a problem in Australia as well, particularly with aged care workers not wanting to get the vaccine.
Yeah. So how do we improve that in terms of the confidence of well, whether it's the confidence or the complacency of healthcare workers, as you mentioned, the three C's about complacency, convenience, and confidence in vaccine hesitancy. How do we improve on that in terms of healthcare workers?
I think we have to improve our training of healthcare workers, that we have to provide them with information about vaccines. They need to know how this vaccine was developed, why it was developed so quickly. So they need to be educated so that they can pass that information on to others.
And Lisa, what would you say in terms of why was it developed so quickly? It is pretty remarkable that we got a vaccine within a year. And I think, yeah.
We have been working on some IEC materials. The way we've come about that is we've tried to explain that, scientists all around the world have come together and worked together in order to develop this vaccine. That hasn't happened before for diseases. And because they've cooperated, because there's been that community response from the scientific community, we've been able to get the vaccine much, much quicker. That's how we tried to explain it.
The other key technical reason is that we've had so many cases of corona that it doesn't take long to demonstrate a difference between those who get the vaccine and those who don't. Now, the meningitis trials went for 10 years because there weren't that many cases. And so it took a long time to demonstrate a statistical difference. But with coronavirus, it took 3 months in most of the trials.
Yeah.
It is pretty remarkable. And I guess because the case numbers are still around the world and it had such a significant economic impact that there's been more funding available as well, I'm sure. Money just thrown at vaccine development.
But for people in PNG, they don't see that. For people in PNG, the case numbers of malaria have been, and historically have been a lot higher. The case numbers of TB, have been much higher. So even trying to tell that story is quite difficult. For them, their lived experience is very, very different from what we're trying to tell.
Yeah, exactly. The other question that just come through, a comment again about what's information being shared about what risk communication activities through the WHO or others have supported myth-busting of vaccines in PNG. Obviously, Burnett are doing some work in myth-busting in Papua New Guinea, but what other organisations are doing the same as well?
Yeah, I think there are multiple. So yeah, WHO is definitely taking a lead in it. I've been working on another project with World Vision and Save the Children. So I think UNICEF is doing a lot of work. The government is working. Catholic Health Churches is also doing a lot of work. So I think everyone, it is recognised, it is a major challenge in PNG, and everyone is trying to do something to address it. And I think, to be effective, it has to come from multiple sources. It has to, people have to turn on the radio and hear about vaccines. They have to turn on the TV. They have to pick up the newspaper. They have to visit Facebook and be reinforced with the same messages over and over again. I think also, community leaders, we can't estimate the role of community leaders, church leaders in PNG to provide people with information.
Exactly. And in ensuring that the community leaders and the religious leaders are educated themselves in terms of the vaccine.
So one of the things that we've been doing is providing training to community leaders and church leaders, and we've developed information booklets that we give out to community leaders and to church leaders that provides them with the basic information, so when they're going out and about they can refer to it, so that we make sure that the message that they're sharing is correct and it's consistent.
It's very important to get church leaders on Surveys in Australia and the US have shown that the very people that describe themselves as very religious are less likely to get vaccinated. And in the US, it's mainly evangelicals. And of course, in PNG, there may be relationships with those churches in the US. So you need to counter that kind of misinformation as well as the social media misinformation.
Fantastic. Cara, you were going to ask something or say something?
Oh, there's some questions on a Q&A, Rebecca. I don't know if you brought it up. I just want to ask Lisa and Professor Mike Toole, if you got a message, see the huge mistrust is how quickly these vaccines have been developed. And if you have a message for our people, what is it? To alleviate that anxiety and that real concern about how come you did it so quickly over such a short period of time, I don't trust it. So why, say for example, I'm a person in PNG, I'm Pacific, why would I trust you? And what would you tell me that will make me want to trust a vaccine and have it?
Mike, do you want to take this one?
Can you just, I was just looking at a Q&A question. Can you repeat the question? Or Lisa, you go ahead.
Yeah, so I think we have to tell a story. It has to be a story about how the vaccine was developed. So it needs to be the story that, you know, scientists around the world have come together, they've worked together in developing the vaccine. I think, like Mike said, that it was a unique opportunity because the number of cases that presented in a very short amount of time were exponential. And so there was an opportunity to access a lot of data, a lot of research that has allowed us to, you know, use that to develop vaccines. Yeah, but I think you have to turn it into a story that can then be retold. I think the thing about in PNG is just presenting facts and data won't work. Whatever you present, it has to be presented as a story.
Okay, thank you.
So the questions in the Q&A pane were about, Jason from Niue asked a question about the Pfizer vaccine being stored for a month in the fridge.
I've sent him a link to that. It's very recent.
2
to 8, so in the fridge for up to 1 month. That's unopened vials.
Fantastic, thank you. And then the other question was, is attitude to COVID-19 vaccine in PNG the same for immunisation in children?
So there are high levels of vaccine hesitancy across the board. Like I said earlier, there is this confusion about why would you have a vaccine if you're not sick. So if you've got a healthy baby, why would you take your healthy baby to get an injection? One, where the health facility has other sick people, so you're exposing your child to being with other sick people. 2, when the baby gets an injection, quite often, you know, it has a mild fever, it's unwell for a short amount of time. You know, mothers go, well, my baby was healthy, then I got it vaccinated and then it became sick. Why am I going to do that again? So yeah, vaccine hesitancy for children is also high, and it is a concern, and it's something that we are constantly working on. The issues around the COVID vaccine, though, have only exacerbated that. So what we've seen is not only are people hesitant about getting the COVID vaccine, we've also seen accessing routine childhood vaccines has dropped off enormously over the last 18 months, partly because some of the services have been reduced because we can't do the normal outreach, because there are less healthcare workers, because clinics have been closed temporarily because of COVID, because resources have been reallocated to COVID, so they've been taken away from routine health services, including vaccination. So we have seen routine vaccination of children drop off enormously. And that's something else that we need to address, as well as looking at addressing vaccine hesitancy for the COVID vaccine.
Great, thanks for answering that. I don't think there are any other questions that are outstanding. So we might finish there, and thank you very much, Professor Mike Toole. Thank you for your time tonight. That was wonderful. And thank you so much, Lisa Davidson. So in finishing, I'll hand back to Cara to do a closing prayer. But I did also just want to mention that there is through UNSW, Kirsten Black and a few of us are undertaking a survey of healthcare workers and access to sexual and reproductive health during that time. As Lisa briefly mentioned, access to services during the COVID pandemic has obviously been affected. And so there's a survey going around about healthcare workers' access for sexual and reproductive health services for their patients. And Kirsten Black is undertaking this research, and I believe there's an iPad to be won. Is that right, Karen?
Oh, yes.
Yeah, that's right. Fantastic. The survey's also been, I believe, is supported by PSRH as well. It's on PSRH Facebook page too. So thank you very much to Lisa and Mike from Burnett for joining us tonight. Really appreciate your input and insights. Have a good night, everyone.
Thank you.
Yeah.
Good night, everyone.
Okay. Yeah. Thank you, everyone who've been listening. So I know that people are starting to leave, but I think I'm going to tell my story very briefly about vaccines. So what happened was that because of this sort of myth going around in South Auckland, I was thinking, well, one, it's really fast to develop a vaccine. Number two, I don't think I'll get it. However, what happened was on the Sunday, we had prayer, and then it just came on my phone that they were offering vaccines to people in health workers in South Auckland where I work, because they've defrosted some vaccine for the border control workers, and then they weren't taking it up and they didn't want to waste it. So what happened was, a shocking lo behold to my children, I actually went there and I had my first vaccine done. And then my children came back and they said, Mum, what on earth? Why did you do that? And I said, look, I felt really strongly in my heart that I should go and get vaccinated, and so I thought, in our communities in the Pacific, especially at places like PNG, we have a lot of us are Christians. We believe in God. So all I'm going to do is I'm going to pray. I mean, we're continuing to pray in Australia, New Zealand, that, our healthcare workers and all our people in the islands will have the wisdom, the understanding, and the knowledge from on high to guide you with what you need to do in your islands, protect our islands and our people. There's so few of us. That's all. So and with that, I'm gonna end with a word of prayer. Father, thank you so much for your love and your care. Thank you for your wisdom, your understanding, and your knowledge. Lord, we commit this COVID vaccine to you. We commit this situation, Lord God. We don't want our people in the islands to be consumed by this virus and kill them. So Lord, you're the God of life, and you came to give us life. You came to give us understanding, knowledge, and wisdom to be able to guide us in the way that we practice. So Lord, we commit this to you and all our people in Pacific. We thank you for our panelists tonight, Lord God, for the wisdom, the understanding, the knowledge, Lord God, that you have provided us to be able to help our people. Lord, we thank you so much. In your precious name we pray. Amen.
Thanks a lot.
Thank you, everybody.
Have a good night.
Thank you. God bless you all. Thanks, Rebecca.
That was great. I learned a lot. It was very good.
Yeah, it was great. All right.